Hi, I'm Susan Nancarrow, and it gives me great pleasure to give this presentation on developing the Allied Health Assistants National Association with the CEO and founder of AHANA, Mr. Ben Turnbull. I'd like to start by acknowledging the traditional owners of the land on which I'm meeting, the Widjabul people of the Bundjalung Nation. I would also like to draw your attention to the board members who have been instrumental in driving AHANA, and just point out that we have a good mixture of allied health assistants and trainers and advocates for the allied health assistant workforce in Australia. AHANA has been developed in partnership with a company called AHP Association Management, and the purpose of that partnership has been to incorporate AHANA, establish the governance systems and support, provide membership support management, build capacity, mentorship and support, and develop a strategic plan. I'm the CEO of AHP Association Management, and I'm the founding chair of AHANA. That's a part-time role until we can build enough capacity in the board for me to hand that role over to a member of the board. Our team at AHP Association Management brings a good mix of regulatory experience and also development of national registration and accreditation schemes with Anne-Louise Carlton. She's worked in Australia and also with the WHO, and Tom Coogan, who's our company secretary and a chartered accountant. Why form a National Allied Health Assistant Association? First and foremost, it's to promote the best care and outcomes for patients in the community. We believe that the allied health assistant workforce can meet substantial gaps in the workforce need, but at the moment they're not organised as efficiently and effectively as they could be, and we don't have any quality standards for this workforce. So what are the problems that AHANA will solve and for whom? And I like to look at this from the perspective of individual allied health assistants, the organisations they work for, and also the wider systems and structures. So at an individual level, the challenges for allied health assistants are that currently their roles are not standardised, they're not well understood, they don't have a national voice. There's no standard for setting qualifications and practice standards, and there's also no system of quality assurance for training and education providers. We know that there are large levels of variation in the quality of training. We also know that there's a huge amount of variation in job roles, which can make it difficult, if you call yourself an allied health assistant, to have transferability of your role to another setting. For employers, we know that every state and territory has their own employment framework. Several other employers have their own employment framework, and every professional association has set up their own allied health assistant framework. So we're working with probably close to 100 different frameworks for employment for allied health assistants. We also know that there are challenges in the private sector who want to employ allied health assistants but don't have either the capacity or the scale to be able to set up the systems and structures needed. Despite AHAs having been around for 20 years, we still haven't solved the issue of delegation. What can be delegated to whom, and what are the risks, and what creates safe practice? And again, a problem for employers is the lack of standards of training quality. At a global or system level, we know that there are huge workforce shortages in the allied health workforce that allied health assistants can potentially meet, but we don't have any data about the allied health assistant workforce, where they are, what they're doing, who they're working for, which means we don't understand the opportunities, gaps or needs. And we think that by reducing the variations and addressing some of the issues above, we can help standardise the allied health assistant workforce so they can make a much greater and consistent contribution to allied health work in Australia. This is some recent data taken from seek.com. Right now, there are about 2,500 allied health assistant jobs in Australia, and a quick analysis of those shows that around 40% of those are in the private sector. We don't know how many allied health assistants are currently employed in Australia. Our best estimate at the start of this process was around 10,000, but in our discussions with employers and also education training providers, we suspect that it's possibly double that, so closer to 20,000. So AHANA will establish the principles of self-certification. So that means we set a standard of national entry, which equates to a qualification and also sets the practice standards for the profession. By doing that, we then go into partnership with government, and this is called co-regulation, which means that AHANA is guaranteeing to government or whoever is purchasing those services that allied health assistants that are members of our association have minimum qualifications or standards. We know we've set a minimum standard for what determines good practice. They will adhere to practice standards, and we can also provide data to government to help them with workforce planning. So why self-regulate or self-certify allied health assistants? We can create consistency of standards for the workforce, establish quality standards that they can maintain. By doing that, we set better protection for the public because they know what they're getting, or at least the employers are purchasing quality services on behalf of the public. We can provide a trusted source of information about allied health specific areas of expertise, and that will increase the mobility of the workforce. We can accredit the training programs, which will increase the quality and standards of the training programs and ensure that they're more fit for purpose for the allied health assistants, and also create a single point of certification rather than potentially 30 or more different models. But our membership system needs to have some principles. First of all, we recognise that there are a lot of people practising as allied health assistants that may not have qualifications. We need to provide a pathway for them into the system. So it needs to be inclusive. We need to enable grandfathering. We need to recognise prior learning. The system needs to be high quality, so our standards need to be the benchmark for all allied health assistants to adhere to. So in some cases, when we allow people in, there'll be some aspiration for them to achieve a particular standard of training or qualification or prior learning to become a certified member of the association. It needs to be transparent. Everyone needs to know what those standards are and what it means. It needs to be simple, so not too many membership categories. We need to be able to enforce it. We need to offer value for our members. Why are they going to become a member of AHANA? And it needs to be integrity. It needs to have integrity. Everyone needs to trust the system of certification that AHANA is endorsing. So, as I said, we'll have a threshold for entry, which will establish minimum allied health assistant competencies. There will be a minimum standard of qualification and ultimately the courses that AHANA will accredit. But as I said earlier, we will recognise prior learning in equivalence. There needs to be adherence to a professional code of conduct and demonstrated experience. And people need to demonstrate that they're maintaining those standards through continuing professional development, which will be part of their membership. We have a bit of a challenge compared to other professions. Other professions simply accredit a course. So if you want to be a speech pathologist, if you complete an accredited speech pathology degree in Australia, you'll be eligible for membership to the Speech Pathology Australia, so the professional association. We don't have the same standards for allied health assistants. We have multiple pathways, multiple roles, and we're going to have to try to bring that together across a very heterogeneous workforce for AHANA. So how are we going to do that? We're mapping to the Australian Qualifications Framework, or the AQF, and the 3 tiers that are of relevance to allied health assistants are levels 3, 4 and 5, which equate broadly to a Cert 3, a Cert 4 or a diploma. The level of entry that we're looking at is the level 4, so a Cert 4 in allied health assistants, but as I said, we will have recognition of prior learning. We're also looking at the potential for a diploma level endorsement for allied health assistants, but at the moment we understand that there isn't a clear pathway in a career pathway to support that, and we've had some resistance from employers around that. So that won't start immediately, and we will have a lot of consultation with industry before that takes place. So what I want to present now is the results of the consultation we undertook with the sector through online surveys, a live and recorded presentation, and we provided a written report which people could provide feedback on. We had feedback from every state, including Chief Allied Health Officers, employers and allied health assistants. So these were the respondent locations: Queensland, Victoria. You can see we had responses from every state and territory. I'm pleased to say that the respondent roles, the largest group were allied health assistants, but we also had feedback from professionals, workforce branches, training providers, managers, and other sectors. The three most important issues facing allied health assistants were seen to be career development opportunities, recognition and valuing of allied health assistants, and ensuring higher pay. The five most important member benefits were access to continuing professional development, employer recognition, regulation of professional standards, state territory award wages, and lobbying and advocacy for allied health assistants. Largely, the feedback was positive. We did have some naysayers, but I have to say not as many as we expected. This is still a contentious area. People want us to justify the cost and value to members, clarify the use of terminology, particularly where certain terms like advanced practice have particular industrial meanings in some states. We had feedback to ensure that the membership structure was simplified and to clarify the need or justification for insurance. People also provided feedback on the perceived risks and challenges, and these were reluctance from private sectors employers, the perception of the threat from allied health professions, differences in qualifications in state industrial agreements, resistance if the fees are too high. I think this is quite an important one. People having to get credentials that they didn't previously need. Self-accreditation, why don't we go with APRA? And to ensure that we're not duplicating systems or overlapping what's happening with the professional bodies. So in response, we've simplified our professional structures. We've added a couple of membership categories, which are students and non-practicing or honorary members. We're looking really at ensuring that the fees are affordable, but can ensure the sustainability of AHANA. We've clarified and simplified the terminology, and we're reasonably comfortable with that now. And we've separated the insurance from the membership so people can purchase that when they want to. So what are our next steps? We will finalise the membership bylaw, which will endorse all of the points and the feedback that I've just raised at our annual general meeting on the 28th of November. And we're aiming to open membership at the start of January 2023. Initially, we will have a grandfathering clause and inclusive entry criteria. Thank you very much, and we look forward to your feedback.